Hi, guys.
Good morning, everyone that's joining in. All right, so we're going to get started right on time today. Welcome, everyone. This is session IC 95, which is electrical stimulation and improved seating outcomes, a literature review, and a clinical application. I will present Nathan Casey for you. He's going to take over. Everyone, please keep yourself muted until the end and put any questions that you have into the chat, and Nathan will address those at the end. So take it away, Nathan.
Hi, everyone. As mentioned, my name is Nathan Casey, and I'm a physical therapist. I want to first just say how honored I am to be here today to talk to you all. So thank you for attending. Also, a huge shout out to all of the ISS team, all the volunteers, the University of Pittsburgh for making this event possible. It's been a tremendous event so far, and I can't wait to see you all in person, hopefully at the next ISS. So as mentioned, I'm going to be talking about electrical stim and improved seating outcomes. We're going to do a deep dive into a lot of the literature on electrical stimulation. We'll talk some clinical application, and then we'll also have some case studies at the end of the presentation. A little bit about me and my path to this presentation. So I'm a physical therapist, as mentioned, at Ohio State University Wexner Medical Center. I work in inpatient rehab at Dodd Hall, where I'm on the spinal cord injury team, the brain injury team, and I'm one of two therapists that work in our inpatient seating clinic. My counterpart, Steph Cooley, is actually presenting along with another therapist from our outpatient seating team on another session right now. So big shout out to them. Go check out their presentation on demand. It's on collaboration across the continuum, and you'll get to see some of the things that we're doing at Ohio State. This topic kind of came to be because as I transitioned into practice in seating, I already had a substantial rehab background. Electrical stimulation was a modality that I was utilizing every day in the clinic. And I was curious because I knew the physiologic benefits of electrical stimulation, and I was curious as to how that translated into improved seating outcomes. So naturally, I started doing some research about 3 years ago when I got into seating. Little did I know then that it was going to lead to this presentation. So here we are at ISS, and here goes nothing. So first of all, I have no financial disclosures or conflicts of interest with any of the information presented in this presentation. We have three main objectives today that we're going to cover. So we're going to identify 3 different types of electrical stimulation and identify their therapeutic application. We're going to understand the 6 physiological benefits in which electrical stimulation has been shown to improve seating outcomes. And we'll demonstrate the ability to analyze 2 different case examples to maximize capacity for clinical application of electrical stimulation in seating. Before we really dive into the literature, though, I wanted to take some time just to review electrical stimulation. It's a modality that's been around for decades in the rehab world, but is starting to be investigated more in terms of seating. And so just to give you guys some background content knowledge on what electrical stimulation is and how that technology can be harnessed to improve outcomes. Before we dive into how electrical stimulation impacts muscle fibers, I think it's important to understand what normal physiologic muscle recruitment is when we're at a healthy baseline. So we have 3 different types of muscle fibers. We have type 1, type 2A, and type 2B muscle fibers. Type 1 muscle fibers are the small, slow, slow twitch muscle fibers that have a long endurance period. So when we think about type 1 fibers, try and think about like a marathon runner, right? They need that muscle fiber to be firing for a prolonged period of time. As the task demand increases, we're going to see recruitment shift towards type 2B, which is going to be a very large, fast fatiguing type of muscle fiber. And so there we can kind of think about like a sprinter. So we utilize Henneman's size principle to understand how our body recruits motor neurons at a healthy baseline. And what that means is that we start with that type 1 muscle fiber, and then as that demand increases and the task demand increases, we see a transition to type 2B. That's different than how recruitment exists with electrical stimulation. So we actually see a reversal of that size principle, where we go from recruiting type 2 muscle fibers first to type 1. And what that means is that our body's response to electrical stim results in increased fatigue at a quicker rate than normal physiologic muscle recruitment. One thing that we do have the ability to do, though, is increase stimulation intensity to increase motor neuron recruitment. And so we'll talk about that here in just a second. First, I want to actually go through defining what electrical stimulation is, though, and what types of electrical stimulation exist. Electrical stimulation is defined as electrical impulses delivered via an external unit to a predetermined area of the body for a therapeutic purpose. So there are multiple applications over muscles, nerves, bones. It can be transcutaneous, meaning over the skin, or it can be implanted. Each one of these serves a distinct and different purpose depending on the location, the parameters used, and the duration of that stim. Today, we're really going to be isolating it into 3 different types of electrical stimulation. So we're going to talk about neuromuscular electrical stimulation. We're going to talk about functional electrical stimulation, or FES, which is actually a type of NMES, but used for a functional purpose. So instead of just putting the electrodes on somebody and letting the machine do the work, we're actually incorporating patient or client movement into the electrical stimulation. So think about maybe putting it on quads and glutes to help with performing a sit to stand, or putting it on the shoulder, the tricep, the wrist extensors, and the finger flexors to work on like a forward reach and grasp of an object. TENS, on the other hand, or transcutaneous electric nerve stimulation, is another type of stimulation that we'll cover in this presentation. That's a little bit different than the first two because that's primarily at a sensory level. So it's not utilized to actually get a muscle contraction. So as I mentioned, the technology of electrical stimulation has been long studied in rehab, and the FDA here in the United States has approved applications of electrical stimulation. So for neuromuscular electrical stimulation, we see that the benefits are relaxation of muscle spasms, prevention of disuse atrophy, increasing in local blood circulation, re-educating muscles, maintaining or increasing range of motion, and then prevention of DVT post-surgery. TENS, as I mentioned earlier, was more at that sensory level. So what TENS really helps with is modulating pain, specifically chronic pain, but then it can also be an adjunctive treatment to acute pain. When I think about seating, obviously our first priorities are always maximizing wheelchair fit and the individual's function within their seating system. But I feel like most times my patients are dealing with some degree of spasticity, atrophy, decreased circulation, or weakness. And so if electrical stimulation can be utilized to modulate those things, I think that we as seating professionals need to be educated about their utilization so that way we can maximize our outcomes. There are 3 different parameters that are available to adjust on pretty much every commercial electric stim unit. The main ones are frequency, which is measured in hertz, and that's the number of electrical impulses that are delivered in a single second. There's pulse width, which is measured in microseconds. And so that's also called phase duration. You might see that in literature or on different pieces of equipment, but that's the time of a single electrical impulse provided via the unit. And then there's intensity and amplitude that's measured in milliamps, and that's the strength of the electrical current that's being provided. So here we have just a little bit of a graph for visual learners. We have the frequency, which is again measured in hertz. That's the number of pulses in a single second. We have pulse width, which is the total amount of time that a single impulse is on for. And then we have intensity or amplitude, which is the total amount of electrical current that's being provided. So we mentioned earlier neuromuscular electrical stimulation being primarily at the motor level. That means that it's going to help with actually getting a contraction for somebody. We also mentioned that TENS is going to be at a sensory level, so it's primarily going to help with modulating pain. The intensity is going to be variable depending on the individual and the location that we're applying that electrical stimulation in the body. But the frequency and the pulse width are going to be different between neuromuscular electrical stimulation and TENS. So with NMES, typically the frequency is lower, while with TENS, the frequency is higher. And then with neuromuscular electrical stimulation, typically the pulse width is going to be between 200 and 500, and that's going to be higher than what it is with TENS. An emerging area in the literature is wide pulse width neuromuscular electrical stimulation, or FES. And so remember, pulse width is the amount of time that a single electrical impulse is on for. Traditional NMES would be somewhere between that 200 and 500 range in terms of the amount of time that that single impulse is delivered. Typically, individuals that have lower motor neuron injuries, so we're thinking lower motor neuron SCI like a cauda equina, individuals with AIDP or CIDP, post-polio syndrome, and peripheral nerve injury, they won't respond to traditional stim because they have a lower motor neuron injury. But what we're seeing in the literature is that when we use this wide pulse width, meaning longer on times, we're going to see muscle contractions with individuals that have lower motor neuron injuries and typically wouldn't respond to stim. There is variable frequency depending on the pulse width. So those two actually have an inverse relationship. As we go up in the pulse width, we can only fit so many pulses in a single second. So here in the United States, we have approval to be able to utilize wide pulse width up to 3,000 microseconds or 3 milliseconds, but there's an inverse relationship. And so when we go up that high in the pulse width, the frequency has to come down because we can only fit so many of those pulses in a single second. And that has important implications for pain that we're going to talk about here in just a moment. So this graph should look familiar. This is what we talked about earlier with frequency, pulse width, and amplitude. With increased motor neuron recruitment, if that's our goal, if we want to get a stronger contraction for our patients, we have two options. We can either increase the intensity or we can increase the pulse width. Increasing the intensity, remember, increases the total amount of electrical stim that's being provided, while increasing the pulse width increases the amount of on time for a single impulse. So there become more distinct on and off periods with a wide pulse width. I've had some patients almost liken it to kind of like repetitive bee stings if it's at a high level and if they have good sensation. So obviously that's a little bit of a barrier. We don't want to hurt our patients. We don't want them to feel uncomfortable. The decreased sensory neuron recruitment, meaning that if we can modulate how much sensation somebody is feeling from that electrical stimulation, we can change that by increasing the frequency. So by increasing the frequency, that's going to help with providing more pulses per second that's delivered to the patient. And so what that means is that there are less distinct on and off times, and it might start to feel a little bit more like pins and needles type sensation for the patient. So it really is kind of a balance. We obviously want to make sure that we're getting a muscle contraction, but we don't want our patients to be in pain when we're utilizing this. Next, we're going to transition a little bit into talking about how the literature supports the use of electrical stimulation in seating and positioning. There are several studies that demonstrate the benefits of electrical stimulation directly to seating outcomes. Other studies that will be presented, we have to kind of extrapolate the findings a little bit because we know what the physiologic benefit of this stim is, and then we have to kind of draw those lines together to understand how it translates into seating. So as I mentioned earlier, these are the benefits of electrical stimulation. We have increased blood flow, reduced muscle spasms, muscle re-education, decreased pain, increased range of motion, and decreased atrophy. Naturally, those things translate to seating outcomes. And like I said, we're going to draw those lines together for some of the studies. One downside in the literature is that most of the studies that evaluate this technology specifically for seating outcomes are smaller studies. And so more literature is needed to really support and demonstrate exact correlation of how electrical stimulation can improve seating outcomes. But a lot of this, again, we can start to infer because we know the physiologic benefits. So we're going to do a deep dive into the literature. We're going to talk through 12 different studies in this presentation that analyze different impacts throughout the seating world. So we're going to look at muscle anatomy and physiology. We're going to look at cardiorespiratory function. We're going to look at seated pressure. We're going to look at spasticity, sensory function, and then mobility and motor function, primarily as it pertains to the upper extremity function and trunk function. First, we're going to dive into some studies on muscle anatomy and physiology. Throughout this, feel free to put questions in the chat on any of these studies, and then we can do our best to circle around to it at the end of the presentation. The first study we'll look at was a literature review of 88 different articles. All of these articles utilized FES and NMES. The study looked at how electrical stimulation impacted body composition and metabolic profile after spinal cord injury. So what we found was that, or what this study found, I shouldn't say we, I wasn't one of the people involved in the study, but the study demonstrated that individuals had increased skeletal muscle cross-sectional area and increased lean muscle mass with use of FES and NMES. They also demonstrated improved glucose metabolism and changes in insulin sensitivity. I put stars next to those last two because those things have been shown to be impaired in at least 2/3 of individuals post-SCI, which puts them at a greater risk for cardiometabolic disease. Cardiometabolic disease is the #1 cause of death in all able-bodied individuals, but the increased risk of death for individuals with spinal cord injury as a result of cardiometabolic disease skyrockets to up to 10 times higher. So if we can impact this in our patients by utilizing this technology, I think it's definitely worthwhile. There was no consensus on the optimal duration and frequency of the use of this FES and NMES due to the large amount of studies that were included. However, they were able to conclude that 2 times a week was no different than 3 times per week. This isn't an image from that particular study by Gorgi. However, it was one of the 88 articles that was included. And the main thing I want to look at here is just the muscle cross-sectional area with the arrow on the right and the arrow on the left. So that's gluteal tissue. We can see here the right gluteal tissue has a lot less cross-sectional area. And that's because this individual had an L4, L5 disc herniation that impacted the innervation to the right glute. We can see the atrophy from side to side, again, indicated by those arrows. Obviously, atrophy and decreased cross-sectional area can lead to greater risk of pressure sore formation. So that has important impacts on how potentially electrical stim could help to increase that muscle cross-sectional area and help prevent pressure sores. The next study we'll look at evaluated 45 individuals post-SCI. It looked at how lower extremity FES cycling promoted physical and functional recovery. So they had 25 individuals in an experimental group that received 45 to 60 minutes of FES cycling 3 times a week for an average use of a little greater than 2 years, kind of 2.5 years. And then they had 20 individuals in the control group that received passive motion and stretching as the primary intervention. What they found is that quadricep mass was increased 36% greater than the control group in the experimental group. Hamstring mass was 30% greater, and fat mass was 44% less, which also has implications for that glucose intolerance and cardiometabolic status that we talked about earlier. Here we can see the anterior thigh component, the posterior thigh component had increased cross-sectional area with the use of FES, while the gluteal tissue had an increase, but it wasn't deemed statistically significant. This study also looked at the perceived level of individuals' physical function, as well as how they could perform different roles in their life with limited physical function. And so that's through the SF-36, which is a self-reported patient questionnaire. Individuals that participated in the experimental group, so received FES, had higher perceived physical function and perceived that their roles weren't as impacted by their physical function. It also looked at FIM, which is the functional independence measure. It's a tool that we used to utilize in inpatient rehab here in the United States that tracks levels of independence with individuals. And so what we see there is that individuals that were in the experimental group demonstrated increased independence in self-care, sphincter control, transfers, and wheelchair locomotion. So I thought this was a great study just because it looked at kind of multifactorial, not only physiologic, but also how people perceive their disability and what people's independence level was. The next study specifically looked at denervated muscle, so lower motor neuron injuries. And as we know, lower motor neuron injuries are often associated with increased atrophy compared to upper motor neuron injuries. They're consistent with increased loss of bone density and then decreased blood supply to skin and tissue. Remember, these individuals don't respond to traditional NMES, but they can respond to that wide pulse width stim. And remember, that's going to be greater than 1,000 in terms of the pulse width, 1,000 microseconds. What this study found is that atrophy can be mitigated and hypertrophy can actually be possible. Obviously, this has impacts for seating because if our individuals have a lower motor neuron injury and they have significant muscle atrophy, that's going to impact tons of different things about how we select different components of the chair and how we educate our patients. So if we can utilize this technology to help with mitigating the risk of atrophy with lower motor neuron injuries and potentially even cause hypertrophy, I think that that's promising. Here, I wanted to show just that all SCIs are not created equal. So the individual on the left in slide A has an upper motor neuron SCI, whereas the individual on the right has a lower motor neuron injury. And so what we can see is just the drastic difference in muscle tissue that's present from A to B. These individuals were both about 2 years post spinal cord injury. The image in B, the one on the right, we see increased areas of white, brighter whites. And what that indicates is increased bone density as opposed to the individual here on the left. And so what we know is that bone density obviously has implications with seating as well, and increased risk of fracture. So again, if we can utilize electrical stimulation to help improve these things, I think it's certainly worthwhile. Next, we're going to transition into talking about cardiorespiratory function and how electrical stimulation can improve that. We will notice that a lot of individuals post SCI or post neurologic injury live more sedentary lives. And so typically they could have more impaired cardiometabolic function, cardiovascular function compared to their healthy baseline. So the first study looked at how the effects of assisted ergometry training with FES impacted exercise capacity and functional ability in subacute stroke patients. So they had a relatively small sample size here of only 16 patients, but they utilized lower extremity FES cycling in the experimental group, meaning that they were applying the stim, and then the control group just got cycling without any stim. And what they found was that individuals that participated in the experimental group had improved 6-minute walk times, had improved peak oxygen consumption, improved metabolic equivalency, improved estimated anaerobic threshold. However, there was no significant difference in exercise capacity or functional ability. The main things, again, we look at the 6-minute walk time being statistically significant, the VO2 max being statistically significant, and the metabolic equivalent and time to anaerobic threshold. And so those are all important things that indicate improvements from a endurance cardiovascular standpoint. The major takeaway as it pertains to seating here is the fact that people that underwent the cycling program had a higher level of fitness after that cycling program. And that has implications for overall health and sustained participation. This could increase independence and overall function from a seated position. And so again, could be beneficial for improving cardiovascular function. The next study that we'll look at demonstrated the effects of functional electric stimulation with use of upper body ergometry, so cycling with your arms on resting cardiovascular outcomes in individuals with tetraplegia. So again, small sample size, only 5 participants in this, and this is something that's pretty consistent with a lot of the literature with eStim as it pertains to seating. But we had individuals that were 3 to 25 years post SCI, and there were a total of a 12-week upper extremity ergometry cycling program with FES. People had improved mean arterial pressure, or MAP, which is an average of the arterial pressure throughout one cardiac cycle. MAP accounts essentially for flow, pressure, and resistance within your vessels. And so in other words, MAP kind of assesses how well your vital organs are perfused. The study found that there was no change in resting heart rate, but there was increased time and distance cycled to fatigue. So what we see an overall higher level of fitness after participating in this study. Individuals nearly doubled their time and more than doubled the distance cycled to fatigue. We also see a slight decrease in overall blood pressure. So individuals went from 91.1 MAP to 87.7, meaning that their overall blood pressure decreased while maintaining healthy blood flow to vital organs. Next, we're going to jump into looking a little bit at seated pressure and how that can be impacted by electrical stimulation. So the first study that we'll talk about had 13 participants with SCI, and they evaluated the effect of surface electrical stimulation on the gluteal muscles to evaluate seated pressure. What they found was that when they had electrical stimulation actively on the glutes when somebody was sitting, that there was a decreased interface pressure and a decreased gradient pressure, both related to pressure sore prevention and improved pressure mapping. So we see here that the images on top are when that stim was turned off, while the images on the bottom is when the stim was turned on. Obviously, nobody wants to go around all day with stim on their glutes, and that poses its own inherent risks to skin and tissue health. But I think the important thing to consider here is the fact that even with one session of electrical stimulation, that we can modulate that tissue, and then we can cause changes at the physiologic level. So it doesn't have a direct correlation necessarily to prolonged seated outcomes, but it shows promise that maybe it could be part of a maintenance program to help with somebody improving their overall seated pressure throughout the day. The next study did actually look a little bit at more prolonged usage. So they had 8 participants that participated in a three time per week cycling program for 8 weeks. And then they did pressure mapping pre and post intervention. What they found was that there was a drop in average seated pressure and a drop in mean maximum seat pressure, but neither was statistically significant. So although there was a strong trend towards a decrease in average pressure and mean maximum seated pressure, it might be more beneficial for future studies to be able to look at more longitudinal use or to increase the frequency at which somebody is utilizing this equipment. The next study, in addition to looking at seated pressure, looked at gluteal blood flow and oxygenation during electrical stimulation, and compared that to what those outcomes were when somebody completed normal pressure relief. So all the individuals in the study had a spinal cord injury and were able to perform independent pressure relief. The main things that they measured again were pressure via pressure map, regional blood flow, and tissue oxygenation. They found that when somebody performed normal pressure relief, that they experienced improved pressure distribution, increased blood flow, and increased oxygenation to the gluteal tissue. With stim alone, they saw improvements in overall pressure and blood flow. So stim obviously isn't ever going to take the place of pressure relief. Everybody still needs to be performing pressure relief. That's a fundamental thing that we all teach our patients. But it can be a good adjunct to somebody's overall pressure management program. The frequency of the stimulation could make stim more beneficial long-term as well. So if we're doing a higher degree of like the number of times per week that stimulation is supplied to the gluteal tissue, or increased frequency throughout the day, we could see better outcomes as well. This study showed via pressure map just how somebody had differences between pressure relief movements and stim. So A is with no stim and no pressure relief movement. B is with no stim but a forward lean. C is with the lateral lean. D, somebody kind of reset again. And then E, they had just stim on and no pressure relief. So when we combine B and E, we can see that those are relatively similar pressure maps, maybe a little bit of increased pressure here on the hamstring in E, specifically on that left side. But overall, even without pressure relief movements performed, we see a pretty solid pressure mapping that I think we would all be relatively happy with in the clinic. Next, we're going to jump into evaluating how spasticity can play a role in seating and how electrical stimulation can help to modulate that. So spasticity, at least for my patients, is something that I feel like I'm constantly battling because individuals will have spasticity that throws them out of position, makes them uncomfortable, causes them to have increased shear, things like that. So the first study that we'll look at evaluated electrical stimulation parameters on managing spasticity after spinal cord injury. Again, this was another systematic review, so a total of 23 studies and 389 participants in these studies. What they found is that when measured by the modified Ashworth and some other secondary measures, that individuals that received NMES and FES acutely decreased their spasticity by 45 to 60%. Due to the large amount of studies that were included, we're unable to establish specific parameters for spasticity reduction based on this study. But what we can see is that here, the most common method to measure spasticity in these patients was the modified Ashworth scale. The major muscle groups that were evaluated included the knee extensors, knee flexors, hip adductors, plantar flexors, dorsiflexors. So primarily muscle groups in the lower extremity. And then the percent change from baseline after acute usage of electrical stimulation was anywhere from 0 to 77%, with an average of 45 to 60% decrease immediately after taking that electrical stimulation off. The next study compared TENS and FES, but also looked more longitudinally. So how long after somebody received that intervention of electrical stimulation was their spasticity reduced. So they, again, utilized TENS and FES with these parameters. They utilized the modified Ashworth scale and the SCAT scale. They measured spasticity immediately post application of FES, 1 hour post, 4 hours post, and 24 hours post to evaluate how longitudinal that reduction in spasticity was. What they found is that FES and TENS can be equivalent for spasticity reduction for up to 4 hours, but that FES may be more beneficial for patients with spastic reflexes, which typically is individuals that have upper motor neuron injuries. Here we can see that the green in this image is the amount of individuals that had a change from baseline with the addition of electrical stimulation, whereas the pink is individuals that remain the same. These are broken down into immediately post, 1 hour post, 4 hours post, and 24 hours post. So generally individuals demonstrated more improvement in that 1 to 4 hour time period with very little carryover into that next day. So if we have a patient that or a client that is experiencing spasticity that's a persistent problem at a certain time of day, maybe we could set them up with a home unit to be able to modulate their spasticity for their trunk or for lower extremities as part of just their regular maintenance program throughout the day. One important consideration is that TENS did demonstrate some improvement in knee extensors even at that 24-hour point. So again, small study, but could evaluate this on a larger scale in future studies. We're going to jump into mobility and motor function next. So the first study evaluated how functional electrical stimulation to trunk muscles could impact wheelchair propulsion. So they had electrical stimulation that was applied at 3 different levels: no electrical stimulation, a low level of electrical stimulation, and a higher level of electrical stimulation. And participants completed 3 different trials of 5 minutes of propulsion with each one of these electric stimulation differences. They measured trunk kinematics, propulsion kinetics, metabolic responses, and shoulder EMG data. What they found was that there was improved gross motor efficiency, which means that there was more power that was produced per energy expended when somebody had that higher level of electrical stim on. So this is just an image from that study. It just shows where they applied the electrodes. So they applied them on rectus abdominis and then also the multifidus in the low back. And then this was their setup. So they used a smart wheel to track those kinetics. They used motion capture analysis and EMG data, as well as a metabolic system to be able to track cardiometabolic improvements. Again, the main finding from this study was the fact that individuals had improved efficiency with propulsion when that stim was on. The next study looked at the effect of functional electrical stimulation and therapeutic exercises on trunk muscle tone and dynamic sitting balance in persons with SCI. So they had an experimental group that received stim and exercise, and then a control group that received just exercise alone. They stimulated the rectus abdominis and the erector spinae for a 6-week program with therapy 2 times a week. And the outcomes were assessment of the muscle oscillatory frequency, which describes the intrinsic tension of the muscle in a resting or passive state. So a higher MOF is equivalent to more muscle tone. And they also looked at limits of stability. What they found is that individuals that received this electrical stimulation during this 6-week program had improved muscle oscillatory frequency or increased muscle tone, and that their seated balance specifically into the flexion position improved. So on top, we can see increase in muscle tone from pre to post intervention for both erector spinae and rectus abdominis, but no statistically significant changes with TheraX alone. On the bottom, we see a drastic improvement in flexion, so a 31.3% improvement with FES, while there was a 12.1% decrease into flexion for individuals with just therapeutic exercise alone. And then no statistically significant changes for lateral loss of balance. Obviously, the implications here is that individuals that have more muscle tone and more ability to go into a flex trunk position when they're in a seated position might have more access in the community, increased independence, not have to rely on any kind of external support or placing their hands on the frame of the chair themselves as they lean forward to access different parts of their environment. This is actually a repeat study from one that we looked at earlier. This was the one that found that individuals had improved MAP, mean arterial pressure, and increased time and distance cycled to fatigue. But this study also demonstrated that individuals had improved hand function as measured by the capabilities of upper extremity index, which is a commonly used outcome measure in the OT world. The main study here, or the main findings here, was that individuals didn't have improvement in shoulders, biceps, wrist extensors, or triceps, but did have improvement in hand function that was statistically significant. While not a direct correlation, the study didn't evaluate wheelchair propulsion. It can be inferred that wheelchair propulsion would improve with increased hand function. Last thing we're going to jump into is sensory function. And this is obviously important for a couple different reasons. If an individual has maintained sensory function on their seated surface, that can almost be a built-in timer for pressure relief, but it can also help with protective sensation, helping to identify if somebody's had, a bump or a burn or something like that on an area below the level of their injury. So this was actually a repeat study too. This was the study that had 25 individuals in the FES cycling group and then 20 individuals in the group that was the control that just received passive range of motion. This study also looked at sensory improvements via the ASIA exam. And what they found is that individuals that underwent that electric stim in the experimental group had an 80% responsiveness to combined motor and sensory scores versus only 40% in the control group. And when they broke that down into pinprick and light touch, as defined in the ASIA examination, we saw pretty big improvements with the experimental group versus the control group for improvements in that protective sensation. So I know that's a really deep dive into the literature, guys. It was a long and arduous process, I'm sure, to listen to all that. But the main point is that there are heavily researched benefits of electrical stim that were presented at the beginning of this presentation. So these were the things that the FDA has stated is indications for the use of electrical stimulation. So that's increased blood flow, reduced muscle spasms, muscle re-education, decrease in pain, increase in range of motion, and decrease of muscle atrophy. And as we start to translate those to seating outcomes, we see that increased blood flow could result in increased tissue health and lower risk for pressure sores. We see that reduction in muscle spasms could lead to decreased postural deviation when in their seating system, as well as less shear and improved sitting tolerance. Muscle re-education could potentially help with increased trunk stability and posture, as well as increased access and independence, as well as improved pulmonary health. Decreased pain could result in increased engagement, increased sitting tolerance, and a relatively higher improved quality of life. Increased range of motion could result in increased function, improved mobility, and decreased compensation in the seating system. And decreased atrophy could lead to decreased peak pressure and less risk for pressure sores. I think our industry is stronger than ever before because of utilization of improving data collection to impact outcomes, emerging evidence, and new products that fit specific needs in seating. By no means is electrical stimulation the solution to all of your seating woes. However, I think it could be a tool that fits a specific need for your patient or client. The purpose in presenting all of this evidence today is to give you more tools for your seating toolbox and to expose you to emerging literature that utilizes technology that's been around for decades. I think one important consideration is the model in which we use to empower our patients and maximize their seating. STIM is just a single tool, obviously, that we have at our disposal, but the real value, I think, comes in how we utilize those tools and how we educate our patients to help advocate on their behalf. We work an increasingly interdisciplinary model with lots of players having a seat at the table to support the patient. And I didn't even list all the players on this slide. So if I left you out, I apologize. But our job is to collaborate with all of these other players while educating and advocating for our patient to ensure that their needs are met and that they have the best possible outcomes, regardless of what tools we utilize. I think depending on our role, we have the potential to utilize this data to improve and translate to seated outcomes. If you're a therapist and you notice your patient has poor trunk control or has persistent trunk spasticity that limits their functional capacity from the chair or frequently causes them to be mispositioned, trial STIM. If you're a vendor or a tech and you notice that these things are persistent problems with the patients that you're working with or the clients that you're working with, consider helping them get or educating them to try and get a referral to therapy. If you're an educator, discuss these concepts with your students. And then lastly, if you're a family member or somebody that utilizes wheel mobility, advocate or question the use of this technology when you're at therapy sessions. Electrical stimulation can be applied in a wide range of situations and have positive outcomes. Lastly, before we get to some questions, I want to take a few minutes to share a couple case examples with you of former patients of mine. So this first gentleman that we're going to be talking about, RD, he sustained a cervical spinal cord injury at C7. He was an ASIA A SCI or had an ASIA A SCI following a snowmobile accident in 2018. When I met him in inpatient rehab, he was primarily utilizing power for positioning, but then also trialed some manual chairs in inpatient rehab. He ultimately ordered a power chair, but then later self-funded a rigid manual chair. And by about 9 months post-injury, he primarily utilized a rigid chair for most of his mobility. His rehab course was that he was stabilized in acute care, transitioned to inpatient rehab where he met me before transitioning to outpatient rehab and having ongoing follow-ups at our assistive technology center on the outpatient side of things for adjustments in the wheelchair. He utilized multiple different types of electrical stimulation throughout both his inpatient and outpatient stays. In inpatient rehab, we did a wheelchair propulsion test where we measured his wheelchair speed at 0.76 meters per second, his propulsion frequency at 1.22 strokes per second, and then his wheelchair propulsion efficiency at 0.62 meters per stroke. He underwent a total of 24 OT sessions with the utilization of FES on upper extremity musculature during functional tasks. And you can see the primary muscles that were utilized with the OTs. He also underwent 12 sessions of PT with a focus on FES for lower extremity and core musculature during functional tasks. There were a ton of other PT and OT sessions that were performed during this case, during this time period where we measured pre and post propulsion speed. So not all of our sessions were focused on electrical stim, but a lot of them did include that. What we saw is that when we repeated this outcome measure about 5 months later, that he had an improved speed by 0.42 meters per second with decreased propulsion frequency. So he was taking less strokes per second, and he was traveling more than double the number of meters per stroke. So we jumped from 0.62 to 1.25 meters traveled per push stroke. The next case example that we'll look at, KC is a 22-year-old female with an SCI following a car accident in 2017. She has a T6 Asia B spinal cord injury. When I met her, she was primarily utilizing a rigid manual chair for all of her mobility. And she'd completed several stints of outpatient rehab prior to me actually meeting her. She had ongoing follow-up at our assistive technology center in the outpatient world for wheelchair needs. And she had a primary complaint of pain and discomfort in sitting. Her pain and discomfort was increased when she had trunk tone that caused postural deviations and loss of optimal positioning. She had previously utilized NMES during PT for lower extremity and core musculature. She did note that she had increased trunk tone when completing functional tasks, including ADL, IADL, reaching tasks, and pressure relief, and that trunk tone caused her to have mispositioning. This was a case where we actually collaborated between the AT Center and inpatient rehab to apply STIM for seating purposes specifically. So we utilized one session of the seating plan of care for application of the NMES. The application of NMES was to core and lower extremity musculature. So we emphasized rectus abdominis, obliques, erector spinae, the quadratus lumborum, and glutes. And then the patient participated in 60 minutes of functional tasks and seated balance in conjunction with electrical stimulation. She demonstrated a decrease in SIJ pain from 8 out of 10 to 2 out of 10 in just one session, as well as decreased spasms and improved positioning, and then overall increased comfort and satisfaction with their seating system. So the overall outcomes of this case, the patient decided that she was going to follow up with outpatient rehab and try and pursue a new plan of care to establish goals and continue to utilize FES for increased comfort and function. She was sent home with recommendations for a home NMES unit, and then provided instructions on the application of the electrodes, the operation of the home unit, and exercises to perform as part of a maintenance program to increase comfort, decreased spasticity, and then increased overall satisfaction with their seating system. And then I think other than just how drastic the outcome was with one session of electrical stimulation, the biggest thing that I learned from this case is that there are tons of opportunities to collaborate in the future with the AT center on the outpatient side of things, and then rehab to help improve outcomes and utilize all the tools at our disposal. So again, I just want to say tremendous thank you to everybody for attending and for all the volunteers at ISS. At this point, I'll go ahead and open it up to any questions.
Nathan, are you able to see the chat at all, or would you like me to read out some of the questions that people asked in that?
I am just pulling it up. If you want to shout some out, though, that would be awesome.
Perfect. It looks like at the beginning, would wide pulse NMES with also applied to tethered cord post-surgical correction?
It definitely could, especially if somebody presented with a lower motor neuron injury. So we're thinking primarily somebody that doesn't have reflexes. And that's usually my go-to that I test to decide if I'm going to apply regular NMES or wide pulse width stim. I will say that wide pulse width stim is, like I said, an emerging technology. And so I do notice that it's not quite as widely available on the secondary market. You can't really buy wide pulse width on equipment that people can utilize at home, say from Amazon. Hopefully that answers your question.
Yeah, next one I see is, do you happen to know the parameters of stim used on the gluteal tissue / duration of those sessions that help to show those improvements in pressure?
I do have them in that article, and I actually have all of the articles listed on slides here. I don't want to misspeak and give you something that isn't accurate, just because of all the articles that were presented. I don't want to misspeak and tell you something wrong, but I could definitely reference that in any of the articles that you're specifically interested in. Yeah,
wonderful, great. There was just a nice comment that said the challenge is each study used different dosing and location of stim, and it makes it hard to evaluate the best setup for maximizing those benefits for seating.
Absolutely. And I think that that's where clinical expertise really comes into play. I think the evidence just isn't there quite yet to support what exactly these parameters need to be for every individual patient. Also, we see drastic differences patient to patient on what they can tolerate from a pain perspective, different body styles, different amounts of adipose tissue. All that affects how well a contraction actually happens. So I think, yeah, it's certainly a challenge, the different dosing and location of electrical stimulation. But I think a lot of it at this time, it just has to be left up to the transgression of whoever's applying that information or the electrical stimulation.
Absolutely, thanks. Next one I see is, at the beginning of the session, transcutaneous e-stim was mentioned. Given that studies show limited carryover of benefit from surface stim, how could transcutaneous or implanted systems be used for long-term needs?
Yeah, I didn't see anything specific to electrical stimulation being implanted specifically for seating outcomes. I know that's something that has emerging literature. So hopefully there's going to be more information on that in the future. Was there another part of that question? I'm sorry, I might have missed that.
Nope, I think you got it.
Okay.
But I think Kathy asked that. So if she has any follow-ups, definitely let us know. Great. The next one that I saw, I think, was with in regards to your second case study. Curious if you happen to know if she was able to get the home unit covered through her funding based on this justification, or do you all run into a majority being out of pocket unless there is an additional funding source outside of traditional insurance coverage?
Yeah, in most cases, I feel like people decide to go out of pocket. And I think the main reason for that is because dealing with insurance to cover a stim unit that maybe costs less than $100, sometimes it's not worth it for a lot of the patients that I work with. So typically I do feel like most patients do just end up getting a home unit that they pay for themselves out of pocket. I know that I have had some patients that do get them funded. Obviously, it just takes a lot longer to be able to get that funding secured.
Yeah, I think kind of Along those lines, someone else asked, which home unit do you typically recommend for clients? Is there preferred dosage? Do you follow up with settings, or does the outpatient team do this? Great presentation, definitely underutilized technique.
Thanks. So I have a couple of go-tos that I recommend. Honestly, I think sometimes the best course of action, if you have a patient that's just going to self-fund it, we all are on Amazon all the time. So at least I am. So I feel like looking at the parameters and picking ones that you know are from reputable brands, things like Chattanooga. Chattanooga is one of my go-to ones that I recommend, just because I know that they've been in the electric stim game for a long time. But picking ones that have a wide amount of parameters, just so that way you have a lot of ability to kind of adjust it and educate as the therapist. I usually try and follow up with the settings if I'm doing this in inpatient. And then luckily, I'm able to communicate with our outpatient team if somebody's staying within our healthcare system at Ohio State, to be able to hopefully further educate on home use in collaboration with our outpatient team.
Awesome. Another question that we see is, any thoughts on NMES or TENS for ALS and spasticity?
Yeah, that's hard. I know traditionally electrical stimulation, people have been tentative to use on a rehab side of things for people with ALS, just because we don't want to further degrade the functioning of those motor units. But I have had some individuals that have gotten clearance to be able to utilize TENS for TENS, not NMES, but utilize TENS to help with pain management. There is some limited evidence on the use of it for spasticity, but I'm cautious with applying it with ALS. I think I haven't seen a ton of literature specific to utilization of NMES and TENS specifically for the ALS population, but that could be definitely something to look into more in the literature.
Awesome. Let's see, a lot of great well dones and thank yous. Next one, what are your precautions for using NMES or FES on areas of body without sensation?
Yeah, so when I was in PT school, obviously you learn that you don't want to apply NMES and FES to areas of the bodies that don't have sensation. But a lot of times we're applying FES in the neuro setting where people don't have that sensation. And I think that recommendation is more from like the orthopedic side of things. You know, if somebody has like a peripheral nerve injury, then obviously we're not going to apply it if somebody you know, doesn't have protective sensation there. But with neurologic diagnoses, it's something that we utilize all the time. The major precaution that I take is just doing diligent skin checks after application. The electric stim unit isn't going to actually hurt them. It's not, you know, you could crank it all the way up to 10 and it's not going to actually hurt somebody. But I always think it's important to just do skin checks. And I always educate my patients, if they're doing it for a home program, that they're always performing skin checks after utilization of the stim, or that somebody else is performing skin checks for them.
Great. Yeah, we had Aaron also comment that the similar thing, that skin checks are just kind of the most important part about working with individuals without sensation.
Yep. I will say that I have had more skin breakdown, almost like petechiae, like kind of busted capillaries with the use of wide pulse width stim for a prolonged period of time. And as that's, again, kind of an emerging technology, I think that that's something that's definitely important to monitor. Definitely see it more with the wide pulse width stim than I do with just traditional NMES, FES.
Awesome. I think we're wrapping up, but I have one more question that I see is any additional specific consideration for the pediatric population?
No, not specifically. The literature shows that it works just as well in the pediatric population. Obviously, you know, you need to have a different approach with kids, probably just so that way you know that, you know, the stim isn't hurting them. But no specific considerations for the pediatric population, no.
Awesome. Does anyone else have any other questions? I don't see any other ones in the chat, but please let me know if I missed any. Perfect. I'm sure Nathan will be happy to entertain some other questions. His contact information is on the slide right now. And with that, I will put the CEU code in the chat and read that out loud for you guys. So our CEU code for this session is 4OPOTG, and those are O's, not zeros.
Thanks, everyone. Hope to see you in person at the next ISS. Thanks for attending.
Thank you, Nathan.